Bordetella pertussis. Bordetella pertussis is a gram-negative, aerobic coccobacillus. Its virulence factors include pertussis toxin, which disables the inhibitory G protein, adenylate cyclase toxin, which increases cyclic adenosine monophosphate, and tracheal cytotoxin, which destroys the respiratory ciliated epithelium. The infection progresses through 3 clinical stages. The catarrhal stage presents with low-grade fevers and coryza. The paroxysmal stage is characterized by paroxysms of intense coughing followed by an inspiratory whoop, giving rise to the term whooping cough, and may also cause post-tussive vomiting. The convalescent stage is marked by gradual recovery from the chronic cough. The disease is prevented by the TDAP and DTaP vaccines. TDAP is recommended for preteens and adults, while DTaP is recommended for children. Bordetella pertussis infection produces lymphocytosis, unlike most acute bacterial infections. Treatment is with macrolide antibiotics, and in patients allergic to macrolides, trimethoprim sulfamethoxazole can be used. Brucella. Brucella is a gram-negative, aerobic coccobacillus. It is transmitted through ingestion of contaminated animal products, for example, unpasteurized milk. The bacteria survive in macrophages within the reticuloendothelial system and can form non-caseating granulomas. Clinically, brucellosis presents with undulant fever, night sweats, and arthralgia. Treatment is with doxycycline combined with rifampin or streptomycin. Legionella pneumophila. Legionella pneumophila is a gram-negative rod that stains poorly with gram stain, so silver stain is used instead. It grows on charcoal yeast extract medium supplemented with iron and cysteine. It can be detected by the presence of its antigen in the urine. Laboratory findings may include hyponatremia and elevated transaminases. Transmission occurs through inhalation of aerosolized water from environmental sources, for example, air conditioning systems or hot water tanks. Outbreaks are associated with cruise ships and nursing homes. There is no person-to-person transmission. Treatment is with a macrolide antibiotic or a quinolone. A helpful way to remember Legionella pneumophila is to think of a French legionnaire soldier wearing his silver helmet, sitting around a campfire, which represents charcoal, with his iron dagger, symbolizing iron, while he is missing his sister, which represents cysteine. Legionnaire's disease is a severe pneumonia, often unilateral and lobar, associated with fever, gastrointestinal symptoms, and central nervous system symptoms. Risk factors include older age, tobacco smoking, and chronic lung disease. Pontiac fever is a milder illness characterized by influenza-like symptoms. Pseudomonas aeruginosa. Pseudomonas aeruginosa is an aerobic, motile, catalase-positive, gram-negative rod. It does not ferment lactose and is oxidase-positive. It is frequently found in water and has increased virulence in acidic environments. Colonies produce a characteristic grape-like odor. The clinical associations of Pseudomonas can be remembered with the acronym Pseudomonas: pneumonia, sepsis, ecthyma gangrenosum, urinary tract infections, diabetes, osteomyelitis, mucoid polysaccharide capsule, otitis externa, also known as swimmer's ear. Nosocomial infections, such as those related to catheters or medical equipment, addiction-related infections in injection drug users, and skin infections, such as hot tub folliculitis or wound infections in burn victims. The mucoid polysaccharide capsule contributes to chronic pneumonia in patients with cystic fibrosis by promoting biofilm formation. Virulence factors can be summarized with the acronym PEEP: phospholipase C, which degrades cell membranes; endotoxin, which produces fever and shock; exotoxin A, which inactivates elongation factor 2; and green pigment. Pseudomonas may cause corneal ulcers or keratitis in contact lens wearers or after minor eye trauma. It can also cause ecthyma gangrenosum, a rapidly progressive necrotic cutaneous lesion caused by Pseudomonas bacteremia, most often in immunocompromised patients. Treatment options include antipseudomonal penicillins in combination with a beta-lactamase inhibitor such as piperacillin, tazobactam. Third and fourth generation cephalosporins such as ceftazidime or cefepime, monobactams, fluoroquinolones, and carbapenems. Although aminoglycosides have antipseudomonal activity, monotherapy with aminoglycosides is avoided because of poor performance in acidic environments.